All right, guys, let's get busy talking about contraception. We're going to be talking about three types of contraception today. So let's go ahead and do an outline of what we're going to cover. We're going to be talking about combined contraception, which are a combination of estrogen and progesterone. And then we're going to move on to talking about copper intrauterine devices, which are a type of non-hormonal birth control. And then finally, we're going to talk about antiprogestins, which are a type of hormonal contraception that's used for emergency contraception as well as termination of pregnancy. So let's go ahead and start by talking about our combined contraception, and it is exactly what it sounds like. It's a combination of estrogen and progesterone, usually given in a pill form. And essentially our mechanism of action here is we're going to have increased estrogens and increased progestins given exogenously. And so what happens here is we have increased levels of these hormones circulating throughout the body, and our pituitary senses this and is like, oh my gosh, there's a lot of estrogen around, there's a lot of progestin around. I don't need to make any more luteinizing hormone or follicle stimulating hormone. And we're going to go ahead and relate this to our diagram that we've been using throughout our reproductive unit to understand this physiology. So essentially, when we have decreased levels of luteinizing hormone and decreased levels of follicle stimulating hormone, this changes the menstrual cycle. And essentially what happens here is we have prevention of the estrogen and luteinizing hormone surge. Specifically, the luteinizing hormone surge is very important for ovulation. So I want you guys to focus on this section of our diagram here that I'm highlighting in red. We have this big surge of luteinizing hormone that leads to the pop that releases our egg and causes ovulation. And when we're changing the entire axis of our amount of luteinizing hormone, we don't get this big surge because the pituitary is sensing high levels of estrogen and high levels of progesterone and is like, I don't need to make any more luteinizing hormones. So we never get that ovulation event. And when we have no ovulation, there's no egg that goes into the fallopian tube to be fertilized. So essentially at the end of this, we have no ovulation. Now, in addition to lack of ovulation, there are some other things that occur when we increase the levels of progestin and estrogen. So the increased progestins are going to lead to increased cervical mucus thickening. And when we have really thick cervical mucus, it makes it much more difficult for sperm to enter the uterus and fertilize the egg. And that's if the egg even ovulated at all. And then the increase in progestins are also going to lead to decreased endometrial proliferation, and this leads to decreased odds of implantation because we need a nicely proliferated endometrium that's healthy and ready to receive an egg in order to have a viable pregnancy. So we kind of have this three-pronged physiologic approach to leading to contraception, and that's by preventing ovulation, thickening cervical mucus, as well as inhibiting appropriate endometrial proliferation. And so our agents that are going to help us do this are going to be combinations of progestins and estrogens to help support the physiology we just talked about. And there are dozens of combinations of estrogen and progestins in different amounts under many different trade names. These can come in the form of pills or patches or rings that are inserted into the vagina. And essentially an OB-GYN specialist is going to choose something for the patient that they think will be best depending on the patient's goals. Some people take these products for contraception, others do it to help with amenorrhea or pelvic pain or too much bleeding, and so there are a variety of products in different balances of hormones that help people with their goals depending on what they want to do. So we talked about the pill, the patch, and vaginal ring, and then we also talked about some indications. So indication being menstrual abnormalities, ovarian failure, hypogonadism, or menopausal hormone replacement, because oftentimes menopausal women are not making enough estrogen, and so we can supplement them with estrogen and progestin depending on what their symptom profile is. Now, it's important that we talk about some adverse effects because I think this is actually the highest yield portion of the step 1 exam when it comes to contraceptives. And so some adverse effects are going to be breast tenderness as well as breakthrough menstrual bleeding. And this makes sense because our uterus and our breasts are hormone sensitive areas of the body, and so when we change these hormones, we can expect to see changes in these tissues depending on the type of hormone that we are giving. And this is going to depend on the specific product that is going to be delivered to the patient. Now, additionally, hormones like estrogen are going to increase the risk of venous thromboembolic events like strokes or DVTs. And so this is going to be concerning in a patient who may be prone to those types of pathologies. And then additionally, patients are more likely to develop hepatic adenomas if they are taking combined contraceptives. So now that we kind of know about some of these side effects, this is going to transition directly into our contraindications. So there are some contraindications that are very strong and show up on the step 1 exam very frequently. One that's super important is going to be smoking in patients over age 35. We know that smoking is going to lead to a hypercoagulable state. We know that people become more hypercoagulable as they age, and if you add in estrogen on top of that, you're going to lead to a very hypercoagulable state that can lead to clotting events. And so if anyone has had a clotting event in the past, like a DVT or a stroke or coronary artery disease, these people should not be taking combined contraceptives that employ estrogen because it makes them hypercoagulable. Additionally, anyone with migraine with aura should avoid these products because migraines with aura, when you take combined contraceptives, are more likely to get ischemic strokes. And then anyone with a history of breast cancer or liver disease should avoid these products as well because these are hormone sensitive tissues that are going to respond poorly when taking combined contraceptives. Next, let's move on to talking about copper intrauterine devices, and these are non-hormonal implantable devices that go into the uterus, and essentially they create a local chemical reaction because copper really agitates the lining of the uterus. And so essentially we have this local inflammatory reaction, and essentially when the copper meets the uterus, it makes a local inhospitable environment, and it's toxic to the egg and the sperm, and this prevents both implantation and fertilization. And this is completely non-hormonal. It's just creating a noxious environment for the egg and sperm as that copper IUD is just sitting inside the uterus, causing that local inflammation. And the indications here are for long-term contraception as well as emergency contraception. So copper IUDs are actually the most effective form of emergency contraception. The only thing that's a bummer about them is that they are very painful to insert because it's a large IUD that's shaped like a T and that has to go into the uterus, and then it can also cause really heavy menstrual bleeding or painful menstrual bleeding as well. And so that is one thing that patients really complain about who have copper IUDs, but some patients like these because there are no hormonal effects, there are no hormones in a copper IUD, and so this is oftentimes something that patients like to lean towards in terms of their contraceptive options. A contraindication of copper IUDs is going to be active PID or pelvic inflammatory disease, and this makes sense. You don't want to be shoving a T-shaped object into a uterus that is actively infected, so if they have PID, you want to treat that first, and then you can go ahead and give them a copper intrauterine device. Other than that, there really are very few contraindications to having a copper IUD. So now let's move on to our last agent here, and this is going to be our antiprogestins. Let's talk about the mechanism of action here, and essentially we're having antagonism at progestin receptors. So that's going to be the key initial insult here. And when we have antagonism, we're going to have increased endometrial growth and decreased endometrial vascularization, as well as decreased cervical mucus thickness. And the way I like to think of this is I like to think of it as like a very bloated endometrial lining that is not well equipped to deal with an egg, because we're going to have a lot of growth, and that growth is going to be poorly vascularized, and then that mucus is not going to be in the right consistency to support a pregnancy. So I think of this really big built up epithelium that is not well equipped, it's not well vascularized. So even though there's a lot of endometrium there, it's not the right type, and so the egg is not going to be able to implant properly. Additionally, the cervical mucus at that time is not of the right consistency to support fertilization, so you kind of have this two-pronged approach to preventing pregnancy in the acute setting. We usually give these products in patients who are looking for very acute emergency contraception. So the classic agent for this is going to be ulipristal, and this is for emergency contraception. And then we can also use it for pregnancy termination. And then we use it for pregnancy termination, we're going to include both a combination of mifepristone and misoprostol. The mifepristone is the antiprogestin that is going to be leading to that biphasic reaction, the increased endometrial growth with decreased endometrial vascularization. And then the misoprostol here is going to actually lead to uterine contractions that are going to slough off that uterine lining and push out any possible products of conception that may have attempted to implant in the endometrial lining. I want to finish this video by talking about a clinical vignette that may show up on test day. So let's say you have a 37-year-old patient who shows up to OB-GYN clinic requesting contraception, and they're 37 years old, and you do some history taking and you find out that they are a smoker, and perhaps they may have migraines as well. The test writers love to ask about these absolute contraindications contraindications to giving hormonal birth control. And so it's always, always important to highlight in your question stems the age of the patient seeking contraception, whether or not they have smoking history or history of DVTs or strokes or migraines with aura. And the test writers may not come out and explicitly say this person has migraine with aura. They may describe the symptoms of a migraine and make sure that you hone in that this person has a history of migraines before prescribing hormonal birth control. And perhaps a good answer choice for this type of patient would be a copper intrauterine device because these are non-hormonal, and then a follow-up third order question may ask about the adverse effects of a copper intrauterine device, which would be heavy bleeding. So I hope you guys enjoyed this video on contraception. I can't wait to see you guys in the next one. Bye!